I don't have anything to disclose. And the purpose of this talk is I'm going to try to give a brief review of some aspects of the parathyroid glands related to the anatomy, some of the embryology, and mostly in relation of the location of these glands and the pathology in order to see what is the role for imaging and how all this interacts with the medical and surgical decisions in these patients. Well, the parathyroid glands are small, and they are so important even when they are so small. They are basically 4 glands, although they can be less than 4 or more than 4. Some patients can have supernumerary glands. And the glands, again, they are small in size and also in weight. The average size is about between 5 and 6 millimeters. And when they have pathology, they enlarge and they are heavier. Usually the parathyroid glands, the normal parathyroid glands, we cannot see most of the times by imaging, unless they are affected by a pathologic conditions when they enlarge and they start overproducing parathyroid hormone. In the average patient, the glands are in a very predicted location. The 4 glands are to superior to inferior, and usually they are positioned adjacent to the thyroid gland, as the name says, para, adjacent, next to the, and they have a specific relation, particularly to the posterior portion of the thyroid gland. Most of the glands, have approximately 80%, follow this pattern, and there's a smaller percentage that can have ectopic location. Eutopic location is the ones who are really close and adjacent to the thyroid gland. What is important to recognize is that the final position of these glands is related to what happens in the development in the embryologic portion of the development of the face and the neck. So the parathyroid glands develop at 6 weeks and migrate caudally at 8 weeks. What is interesting is that the inferior glands develop from the third branchial pouches. Meanwhile, the superior glands originate from the 4th branchial pouch, and I'm going to show you some schemes about it, by 6 weeks, and develop from the ventral portion of the pharyngeal pouches. But they migrate at 8 weeks, and the superior glands, the origin is very closely associated with the thyroid, and also descend with the thyroid, particularly with the lateral portions, the lateral lobes of the thyroid gland. The inferior glands have a close relationship with the thymus and descend within it. Here you have, for example, invertebrates in the embryo about 6 weeks. They have these structures called the branchial arches that are going to be the precursors of many structures in the face and in the neck. These branchial arches have some clefts in the lateral portion, that is ectoderm, and have pouches in the medial aspect of this, and this is pretty much endoderm. The inferior glands originate from the 3rd pouch, and these are in close association with the thymus. Meanwhile, the 4th, from the 4 pouches are originating the superior glands. And here you can see in this scheme that when they start migrating caudally, the 4th, the superior glands that are associated with the thyroid, they have a shorter migration process, and they start close to the thyroid gland. Meanwhile, the inferior glands have a longer migration process all the way with the thymus. Now, in this process of migration, some of these glands can have different positions eventually. Some of the glands or portions of these glands can stay up, superior to the thyroid glands. Some can stay lower to the thyroid gland, and some can go all the way down with the thymus into the mediastinum. This is important because from this caudal migration of the parathyroid glands, basically we are going to have a wide spectrum of locations, And that's going to be important for the role of imaging to identify this. Again, the expected locations are going to be related to the thyroid gland or just inferior, the so-called ectopic glands. But the reality is that you can find glands way up behind the angle of the mandible to about the level of the hyoid bone, but can extend all the way down. You can see glands all the way down to the mediastinum. There are some unusual locations that can be related to inferior or superior glands adjacent to the pharynx, behind the pharynx, the esophagus, along the carotid sheath, and the ones that go all the way down with the thymus can stay really in the upper portion of the neck, or can be completely all the way down into the mediastinum adjacent to the aortic arch. Some of these glands even can get embedded within the thyroid and have an intrathyroid location, as we're going to see later on. Basically, what the purpose of the thyroid gland, the parathyroid glands have an important role for the metabolism of the calcium, with these actions upon the bones, kidneys, and the GI tract. When they are hyper-functioning, basically produce an excess of parathyroid hormone and produce what is hyperparathyroidism. And most of the time is the most common is primary hyperthyroidism. And the most common cause is the presence of adenomas. 80 to 85% of the patients with primary hyperparathyroidism are going to have adenomas, well-established lesions. A smaller percentage can be related to hyperplasia or multiple adenomas, most of the time double adenomas, and a very small percentage of cases can be related to carcinomas. The vast majority of the patients with primary hyperthyroidism have the form that is called sporadic. But some patients have a familial form of hyperparathyroidism, particularly visible with the patient with a multiple endocrine neoplasia, like the MEN1 or MEN2. Remember that these patients, for example, with the MEN1, they are also associated with pituitary tumors or with the pancreatic neoplasm in the other MEN2. That are usually associated with adrenal tumors for pheochromocytomas or with medullary carcinoma. There are some other more unusual forms of familiar origins, but this is in much lesser percentage. One thing I would like to talk about, and this is related also with the migration, the final position of the parathyroid glands in the neck or in the upper mediastinum, in all these structures, is a nomenclature that has been described by surgeons. This is the so-called nomenclature for classified parathyroid adenomas, was developed by surgeons in the MD Anderson, by Dr. Nancy Perrier, a surgeon. And basically, the purpose of this classification was to describe the location of parathyroid adenomas, making a more concise and reliable way to describe the positions in order to get better communication between surgeons, between radiologists and pathologists. And one of the important things is this is based on detailed information that is provided by imaging. It was, when this was described, it was mentioned that it was not enough to say, well, the pathology is located in the superior or inferior glands, but mostly more information is needed to see the three-dimensional location of these glands in relation with the thyroid and with other structures. So this nomenclature is based on quadrants and the anterior and posterior depth relative to the course of the recurrent laryngeal nerve, and particularly with the parenchyma. In the description of Dr. Perrier, she described a classification scheme using the letters A through G. Now, in this scheme from her article, this is from retraction of the thyroid gland. Basically, you can see here the quadrant location for glands that are superior and inferior in quadrants and labeled from A to G. The superior glands basically are adherent to the posterior parenchyma, parenchyma of the upper pole, and some of these glands are really embedded in the parenchyma. Even by surgeries are difficult to see. Sometimes by radiology are hard to see. The glands B are behind or back to the thyroid, to the posterior mid and upper pole of the thyroid gland. Glands C, that is also a superior, but it's much more inferior in location because the origin it has the pedicle is from the upper head and upper pedicle. It's a gland that falls behind and posterior and close to the inferior pole of the thyroid gland and close to the clavicle. But these are posterior glands. The D it's a difficult. Is close to the is in the mid region of the posterior surface of the thyroid, and this is directly over the recurrent laryngeal nerve at the level of the inferior thyroid vessels. And this is also a difficult gland for resection. The gland category C is close to the inferior pole of the thyroid anterior and the external aspect. And this is the easy gland. This is easy to see and easy to operate on, this one. The F is a gland that follows the thymus, and this is a gland that is falling into the thyrothymic ligament and stay in the superior thymus, and also the glands that are all the way down to the mediastinum are considered F. And the G is the adenoma of the gland that is intrathyroidal, is the G intrathyroidal. And basically, the purpose of describing this is to have a better concise information about the position of these glands and to put that in the radiology report, in the operative report, and that could be a better understanding about this, particularly in the patients who are going to have repeated surgery. Here you have some examples in imaging. This is from a CT. This is the type B behind the thyroid. This is posterior to the mid portion of the thyroid. And this usually this gland is in the tracheoesophageal group. This is esophagus, the trachea, mid portion of the thyroid gland. This is the gland type E. This is probably the most common, and this is the most common location of this according to the Perrier nomenclature. This is the gland that is inferior and left lateral to the lower pole. This is the thyroid lobe. This is a gland. This is the type B. Remember, this is posterior to the gland in the mid upper pole. In the tracheoesophageal group, this is longitudinal view of the left lobe. This is hypoechoic elongated structure that is a big adenoma. And here you can see in the lateral reformat, this is the thyroid lobe, and in the tracheoesophageal group, this elongated gland. So this is the second most common location. The most common is this location, the type E. Now, all this information is important for the role of imaging. All of you know that years ago, the surgical treatment of primary hyperparathyroidism was pretty much extensive dissection of the neck for looking and evaluating the glands for gland exploration, but that has been changing to a minimal invasive approach. And for this purpose, there's a need for really good imaging for localization, not only from the usual locations of these glands, but also on the unusual locations. And this is important because with current imaging, the localization of the preoperative localization of parathyroid gland with high resolution, it has a great sensitivity up to about 96% of localization of these structures. It is considered that the success rate for of less invasive techniques equals to the traditional approach. But not only the importance also for the imaging is to identify concurrent thyroid pathology. And it's understanding most of these patients, so as we heard in previous lectures, because of the large prevalence of thyroid pathology, thyroid nodules, it's not unusual that when we look for parathyroid adenomas, we look for also for thyroid nodules. And again, the imaging is essential to detect ectopic parathyroid or tissue or in recurrent or persistent hyperparathyroidism. Talking about the minimally invasive parathyroidectomy, basically the technique that is the most effective and most used actually for the evaluation and resection of parathyroid adenomas, particularly in single lesions. The American Association of Endocrine Surgeons in the guidelines for 2016 indicates that the requirement for minimal invasive parathyroidectomy, number one, is to have preoperative location of imaging. Years ago, and there's a classic quote of a interventional radiology, Dr. John Dobman from the NIH, saying that with quote was that the only localization technique that was required for parathyroid surgery was to locate an expert surgeon for parathyroids. But in this case, basically it has migrated to the imaging. And also, this minimally technique requires some adjunct techniques in surgery, such as intraoperative monitoring of the parathyroid hormone, particularly to see if we are dealing with uni or pluriglandular disease. For this, it is needed to have a tech in the OR with equipment to do an assay of the parathyroid hormone. Basically, what they do is they draw blood, and baseline is when the patient, before they get intubated, draw blood when they times 0 is when they excise what they expect is the gland, and then wait and draw blood at 5 and 10 minutes. And basically what makes the diagnosis is a drop of more than 50% of the level from the baseline. Then they are dealing with the right with the right gland, with the culprit gland. So if there's no drop, they have to keep looking. Now, there are the imaging modalities that are available, and we use mostly are ultrasound and nuclear medicine, but other modalities such as CT, MR, and some invasive modalities are in use. The most common we use are ultrasound and nuclear medicine with Sestamibi, planar imaging, and these are most recently with the SPECT CT. Now, ultrasound has been used for longer time. High-resolution ultrasound is required, and the technique also includes the color and power Doppler imaging and graded compression grayscale, as was described many years ago from the group from Stanford. The scanning technique requires high-frequency transducer. The patient with extended neck, the thyroid gland used as a reference. Important to do transverse and longitudinal images from the submandibular glands to the subclavian vein, and from the midline of the trachea to the carotid arteries, to encompass all these areas where the glands can be located. The parathyroid adenomas by ultrasound characteristics are going to be solid, hypoechoic, ovoid shape. Some have a bean shape or have been elongated. Other shapes can be present. For example, the longer or the larger glands or or larger adenomas can be multilobulated, can be more nodular, some can be triangular, etc. Characteristics, they are hypoechoic by the dense solid component and the cellularity of the adenoma, and the long axis parallels the long axis of the thyroid lobule. This is not the only sonographic appearance, although the vast majority are hypoechoic. They can be heterogeneous. Some of these can be hyperechoic because of bleeding, or some can have some fat. There are some that have more content of fat, that is the so described lipoadenomas, but these are tumors that are rare. Frequently, those adenomas can be cystic, partially or nearly entirely cystic. True cysts are uncommon. Most of these are non-functional, but some adenomas with cystic changes, the vast majority of these are functional. And most of the time, this is because there can be some bleeding within the gland and eventually have some cystic degeneration. And here you can see in this Sestamibi examination, this is the cystic gland with activity in the delayed images. One thing to remember about the ultrasound for parathyroid adenomas is the use of color and power Doppler. The parathyroid adenomas are highly vascular lesions, and these lesions are fed by enlarged branches of the inferior thyroidal artery that have a characteristic polar insertion. And once this branch gets into the artery, and the branch gets into the adenoma, they can present with a vascular pattern or arc rim. Here you can see in this example, longitudinal view, a parathyroid adenoma with a large hypertrophic polar branch, and in this one, classic arching appearance and the branching into the deep portion of the gland. Parathyroid, the ultrasound has some challenges and some pitfalls. One of these, obviously, the body habitus. Patients who are large, who cannot extend the neck very well, are very difficult, or particularly for those glands like in locations B and C that are really deep. Difficult to differentiate from lymph nodes or thyroid nodules, or patients with multinodular goiter. Patients with parathyroid hyperplasia because the glands are small or in the ectopic locations. Localization differentiation with lymph node obviously is, as was mentioned before, normal lymph nodes. For example, this is a big lymph node located inferior to the gland, but the central echogenic area, the presence of color flow in comparison with the distribution. Now, the ectopic locations of parathyroid glands, again, they can originate from superior or inferior glands. This is from a large study of patients with ectopic adenomas. Here you can see the distribution. The most common distribution for ectopic adenomas are located within the thymus, lesser as you can see in other locations, including the mediastinum, just deep in the mediastinum, and other areas that are much less common. Here's a few examples. Here you can see by ultrasound, it's possible to see some of these glands that follow the gland into the thyrothymic ligament region. This is an ultrasound. You can see this is the gland. This is the right innominary. Here you can see the vascularity, the polar branch here. And look at the location, and this located just posterior to the clavicle, the head of the clavicle. Here you see in the normal side in the relation with these vessels. So this patient obviously can extend the neck very well, but also the sonographer have to be careful about looking at these patients. And one of the things that are important to mention is that the location of these glands, and when doing ultrasound, it's important to have deeper portions visualized and have good landmarks to get the correct localization. Otherwise, and for example, the use of clips and the use of sometimes even lower frequency transducer. This is another ectopic adenoma. Here you can see this could be a lymph node. This is very close relationship with the carotid, and here you can see with the use of color Doppler more of the vascularity of this one, and this is with the CT examination, the thyroid lobe, and just lateral was this. This was a patient who had a previous surgery and a patient with an MEN1. There are some areas that are going to be impossible for ultrasound. For example, this ectopic, this is a retropharyngeal adenoma. Here you can see why it cannot be seen by ultrasound, because this is, there's some air, and here you can see in the transverse location. This is a retroesophageal adenoma, as you can see, obviously again, cannot be seen in this. Intraparathyroid adenomas are rare. A recent series located a large number of adenomas in the locations in relation with the thyroid. The vast majority of this is from the University of Pittsburgh. More than they divided this partially intrathyroid and complete in the thyroid when this greater than 50% or completely surrounded by the thyroid nodule. Here's an example of one of these, lobulated, partially intrathyroid. And the main findings they found was that these nodules were solid composition, profoundly hypoechoic relative to the thyroid gland, and with the presence of a polar feeding vessel. Here's an example of one of these intrathyroid parathyroid adenoma in a patient with a family history. This is from another big series when the location of the thyroid gland, most of the intrathyroid adenomas are 90% are in the lower lateral quadrant, and some in the superior pole. And again, the challenge is differentiating for intrathyroid parathyroid adenomas from coexisting thyroid nodules. Ultrasound is good is sensitive for solitary adenomas, but falls to patients post-failed surgical exploration and with lesser accuracy for hyperplasia on multinational glands. Radionuclide imaging, basically biplanar imaging, with the use of MIBI, SPECT, but the most current location, the most higher sensitivity is done for SPECT CT. Here's an example of a lower parathyroid adenoma, and here this is a superior parathyroid adenoma in location B. The Sestamibi SPECT obviously improves the sensitivity for solitary adenomas and double adenomas. And the benefits is the combination of anatomical CT for the functional imaging and discriminate parathyroid adenomas from anatomic landmarks. This is an example of a SPECT CT for a mediastinal ectopic adenoma. The SPECT CT, higher sensitivity and specificity and superior for cases of ectopic and multiglandular disease. This is a patient with an MN1 hyperplastic gland, and here you can see that this is in the left paratracheal location. 4DCT is a method that takes advantage of the perfusion, the hypervascularity of the glands, with change in perfusion over time with rapid contrast uptake and washout. It is imperative for doing multiple phases for the acquisition of the 3D reformats and allows lateralization of quadrant localization of the hyperfunctional glands. And this is very important for the preoperative planning, particularly in reoperation. So in the 4DCT, basically there are three. The findings are the low attenuation nodule in the non-contrast phase, arterial peak enhancement in early arterial phase, and washout of contrast phase. So contrast in delayed venous phase. So this is important, the multi-phase imaging. Now here you have an example. The pre-contrast examination is important because of the higher attenuation of the thyroid gland. This is the nodule here, and this is the arterial phase. You can see corresponds to this nodule of lesser attenuation and the washout in venous phase. Here, so occasionally you can see the feeding vessel, the same as you can see in the ultrasound examination. This is one case of a patient with multiple surgeries with M1, with a left small hyperplastic gland without contrast, and this in the arterial phase, and with a planar reformat in the coronal and in the sagittal reformats. So the 4DCT has an excellent detail for adenomas localization and detection of ectopic lesions, but however has the prime for radiation and increased organ dose too. This is a patient with a double adenoma. Here you can see how is the arterial during the attenuation in the first pass, washout, but the most important thing is that you don't see this in the in the non-contrast examination. And lastly, some interventional procedures, some like ultrasound-guided FNA for PTSA. Some people say that is not a good idea because these patients tend to have some inflammatory changes and fibrosis. And in some patients, sometimes we are requested to do localization just for lateralization, having sampling the internal jugular veins, for example, in these cases. Remember that the upper portion of the thyroid gland and adenomas in these locations are drained through the superior veins and middle veins into the jugular veins. So this patient has to be with the neck extended, and the sampling has to be done really low in the base of the neck, as close as possible, to have the localization of the greater level of the parathyroid, the parathyroid hormone, for example, in this particular case, with the greatest level of parathyroid hormone in the right, and has to be, for lateralization, greater than 10% of the PTH levels. So in conclusion, the current surgical treatment with minimal invasive surgery requires accurate localization of abnormal parathyroid glands. Imaging is useful, if not essential, for surgical planning. Ultrasound and maybe scintigraphy are the first-line modalities, but challenge persistent recurrent hyperparathyroidism with multiglandular disease and ectopic location. Is migrating for increased use of SPECT-CT and 4D CT. These are second-line modalities, but in some centers, these are becoming part of the first-line modalities, along, for example, with ultrasound and 4D CT or SPECT-CT. Thank you very much.